Disclosures. So let's start with a normal artery. You see here intima, media, and adventitia. And here you see a moderately diseased artery. Here's the lumen. Here's the adventitia. And here you see a severely diseased artery with a lumen the size of the ivus catheter. And you see a large plaque burden. Plaque composition by ivus is not very histologically accurate. We define it as hypoechoic, which means that it is less dense compared to the adventitia. Hyperechoic, which means it's as bright as the adventitia, but you don't have shadowing. And calcific, which is as bright as the adventitia, but you don't penetrate the calcium, so you have shadowing, and often you have reverberations, which are highly statistically predictive of calcification. There are really only two causes of reverberations: calcium, as I just mentioned, and metal. So you hear stent metal causing reverberations. Here you see calcium causing reverberations. Now, these intense reverberations with calcium occur most prominently after rotational atherectomy because of polishing the surface, allowing the ultrasound to bounce back and forth between the transducer and the polished calcium. So here you see calcium pre-intervention with a subtle reverberation here, and here you see calcium after rotational atherectomy with multiple reverberations, and here where it's closer to the transducer, as many as 7 or 8 reverberations. Ivus is not the best technique to looking at thrombus, but sometimes you see it. For example, here's a lobulated thrombus in an atherosclerotic artery, and here's a lobulated thrombus in a non-atherosclerotic artery. And then there's something called attenuated plaque. Attenuated plaque is hypoechoic plaque, which means it is less dense than the adventitia and often, quite frankly, black, but you do not penetrate to the adventitia, so it's hypoechoic, it's not reflective, but you don't see the adventitia. And this indicates an unstable plaque, usually a thin cap fibroatheroma, and a plaque that is at increased risk of distal embolization when you implant a stent. This is an example of an attenuated plaque. Again, it's hypoechoic, and you do not see the adventitia. A stent is implanted, and look at all this material inside the stent that embolized distally and caused a periprocedural myocardial infarction. Now, the field of coronary artery disease was fundamentally changed when the pathologist Seymour Glagoff published his paper in the New England Journal of Medicine now about 30 years ago. And he showed that as atherosclerosis is deposited, as plaque is deposited, the vessel grows to accommodate the plaque, and he called this remodeling. Remodeling is a dynamic process. It occurs over time so that you can get an interaction of remodeling, plaque progression on the lumen. If positive remodeling perfectly accommodates plaque progression, you have no lumen change. However, clinically, we don't have the opportunity to look at lesions over time. We typically only see them once. So here's an example of two examples of perfect positive remodeling in angiographically normal reference segments. If you look here, the right coronary artery is only minimally diseased, but when you look at the lumen and the adventitia, there's a huge amount of plaque, and positive remodeling has precisely preserved the lumen dimensions. And this is another example up top of a patient undergoing PCI. You can also have overcompensation. That is, remodeling is greater than the plaque deposition, and that is what is responsible for ectasia. So here you see a patient with ectasia in the LAD and in the circumflex. Look how large the lumen is. Of course, there's atherosclerosis, but the vessel has overcompensated so that the lumen actually grew, and that is what we see reflected and angiographic ectasia. When we look at individual lesions, we tend to classify them as positively remodeled, intermediately remodeled, or negatively remodeled. Well, here's an example of a positive remodeled lesion where the lesion site adventitia, or EM, is greater than the proximal reference. Here's a lesion with negative remodeling where the adventitia is smaller than the distal reference. And here's what we often see at osteal lesions. In this case, a LAD immediately at the site of a diagonal branch in which there's extreme negative remodeling compared to the distal reference, and often only a small amount of plaque accumulation at the site of the lesion. A complete analysis pre-intervention is shown here. We look at the proximal reference, the distal reference, and the lesion. We measure the lumen and the adventitia at the proximal reference, lesion, and the distal reference. And we do a series of calculations. For example, the relationship between the lesion lumen and the lumen of the distal and proximal reference represents an area stenosis. And we look at plaque burden at each of these segments. It seems like a lot of work, but most of this is a calculation, and it really only involves drawing 3 circles. Now, in terms of unstable lesion morphology, beyond attenuated plaque that I already mentioned, here are 2 clinical examples of a patient presenting with acute coronary syndrome. Here in the right, you see plaque rupture with rupture of the fibrous cap at its lateral attachment with a cavity. And here you see in the LAD, plaque rupture with thrombus formation in the cavity that goes into the lumen to cause lumen compromise. Again, as I mentioned, ivus is not the best way to identify thrombus, but sometimes it's pretty clear. And in terms of ivus detection of plaque rupture, about 60% of ACS lesions will have plaque rupture by ivus. The least common cause of atherosclerotic acute coronary syndrome is a calcified nodule. Here's a patient with a calcified nodule at the distal bifurcation of the left main. Pull back from the circumflex to the left main. Here's the calcified nodule. Irregular calcium protruding into the lumen. And here's the LAD pullback. And again, calcium protruding into the lumen at the origin of the LAD. Spontaneous coronary artery dissections are easy to detect by ivus. Here are 2 examples. This patient has spontaneous dissection of the LAD and the ramus. We have the ramus pullback where you see separation of the internal and external elastic membrane with blood accumulation resulting in a hematoma that extends to the left main. You see at the left main the external and internal elastic lamina. And the LAD, a similar finding. Here is a circumferential spontaneous dissection, again with blood accumulation representing a hematoma that extends into the left main. And here's an example of a spontaneous dissection that actually occurs within the external elastic membrane, because you can see the preserved 3-layer appearance that's part of the collapsed part of the vessel. As we know, these tend to heal over time, therefore making the diagnosis is critically important. Here are a few less common findings. This is a muscle bridge in a normal artery. Here you see a normal LAD, and muscle bridge is this echolucent zone surrounding the artery. The echolucent zone represents the intramyocardial course, stops at a septal branch, and then picks up again proximal to the septal. This is a patient with the angiogram pre-intervention. After crossing with a guide wire, you can see 2 new focal stenoses. Angiographically, this looks like a wrinkling, and by ivus you can confirm it. And as you try to trace the EM all the way around, you realize that there are actually 2 EMs caused by folding of the artery that don't connect. So one of these is on one side of the fold, the other is on the other side of the fold, and you don't penetrate into the EM itself. And again, in the mid wrinkle, again, you can't trace all the way around. You can see the EM at one side of the fold, the EM at the other side of the fold, and you don't penetrate into it as well. Here are two examples of true aneurysms. True aneurysms indicated by preservation of the three-layered structure of the artery. Pseudoaneurysms, of course, represent rupture of the vessel and loss of the three-layer appearance. This is an elderly patient with atherosclerosis and a tight stenosis proximal and distal, probably because of the stenosis distally with flow characteristics and post-stenotic dilatation caused by the stenosis proximally. The vessel grew at that point, but you see preservation of the intima, the media, and the adventitia. This is slightly different below. This is a young boy with Kawasaki's disease. You can see the true aneurysm with adventitia, media, and intima, preservation of the three-layer appearance, and the calcific stenosis is a late consequence of Kawasaki's disease, but yet both of these have the clear ivus appearance of true aneurysm formation. A couple of technical aspects I think are important. When you're imaging the aortoosteal junction, you must disengage the guiding catheter. So here's a calcific nodule at the ostium of the right coronary artery, and you can see the pullback from the proximal to the ostial right. We see the aorta. So we've seen a transition from the proximal to the aorta. And here at the at an ostial left main lesion, again, transition from the left main to the aorta, we see the aorta. So that means the guiding catheter has been disengaged, and we can see the true aortoosteal junction. Why is it important to do that? Well, this is a restenotic stent in the left main, but the guiding catheter was not disengaged, and it looks like there's in fact calcification at the ostium of the left main. Unless you disengage the guiding catheter, you do not know whether or not you have imaged the true aortoosteal junction, and that's critically important, especially with a freshly implanted stent, where you want to decide whether or not to cover the ostium and make sure you avoid significant malapposition at the aortoosteal junction. The other point, particularly when you're assessing a left main lesion, is that you must image both branches directly and not tangentially. So you cannot image the LAD from the circumflex pullback, and you cannot image the circumflex from the LAD pullback. They're tangential and in the far field and are inadequate. You can see here this left main lesion. You can see that the circumflex doesn't look too bad by angiography or by ivus, but yet on pullback, there's a large plaque burden with some mild lumen compromise at the true ostium of the circumflex. Now, when you decide you're going to stent a lesion, you have to make two basic decisions: how long and how big. The length is determined by identifying the distal and proximal landing zones as the largest lumen with the least plaque burden, and then sizing it based upon one of several algorithms, and different people use different algorithms, and there's no absolute right way, because at the end of the day, it's as much the post-dilation as is the stent sizing that determines how good an acute result you can obtain. The least aggressive is the smallest of the proximal, or the largest of the distal or proximal reference lumen dimension. The next most aggressive is mid-wall. Then there is reference segment media to media, and then there's lesion site media to media. And this is always discounted, because if you measure all the way to the media of the lesion site, you can result in perforation. This is a typical stented lesion with the same kind of complete analysis as I showed you pre-intervention. Distal reference lumen and EEM, proximal reference lumen and EEM, the minimal stent diameter, and then everything else gets calculated. Sorry, this is a metallic stent. You see the intense reflection of the metal and a single metallic structure. This is a bioresorbable vascular scaffolds. These are both the absorbed scaffold, not as clear as by OCT, but you see both the leading edge and the trailing edge of the scaffold, and there is smearing, however, so you don't get those nice tight boxes that you see with OCT. Now let's look at a couple of examples of lesions that have been stented. This is after stenting. You can see that an impella is in place because there's a high-risk patient with very, very poor ventricular function. Pretty good angiographic result, but on pullback from the left main, from the LAD to the left main, there's an area where the stent is barely larger than the ivus catheter, severe underexpansion that is not seen on the angiogram. Notice that it is hard to distinguish stent metal from calcium, although if you look carefully, you see the two layers, the inner layer, bright layer representing the metal, the outer layer representing calcium, and you can see calcium here resulting in distortion of the stent. These are three examples of malapposition. Malapposition is when the stent is not in contact with the vessel wall. That is distinctly different from underexpansion, where the stent is fully in contact with the vessel wall, but just the size is small. Whenever you see these reflections, almost reverberations, in a metallic stent, it means that the stent is not well opposed. This is mild malapposition, moderate malapposition, and severe malapposition. Now, what causes malapposition? One is a size mismatch, particularly proximal to a bifurcation lesion in which POT has not been performed, as well as calcium, where the stent cannot conform to the rigid calcium as it transitions to the vessel wall. And that's exactly what you see here. You see pretty decent apposition distally, malapposition at the site of calcium in the middle, and malapposition at the ostium because there wasn't a large enough post-stent optimization or pot balloon used, which would have opposed the stent metal to the vessel wall. These are some complications. These are 3 dissections: stent edge dissection, mild dissection, moderate dissection, severe dissection. That's associated with lumen compromise, both moderately and severely. If you have focal dissection without lumen compromise, there are no consequences. It's when you get lumen compromise and you have length that you have consequences such as stent thrombosis or restenosis. A particular type of stent dissection is an intramural hematoma. That is when you have dissection down to the media, blood enters the media, forces the internal elastic membrane inward and the external elastic membrane outward, kind of like a spontaneous dissection. And then you get a hematoma or blood accumulation in the false lumen. So here's the hematoma, here's the external elastic membrane, here's the internal elastic membrane. You've got some length to it, and it starts a little bit right here, but then it gets much larger. Another example, intramural hematoma here, here, here. You almost see merging in terms of a visual appearance of the hematoma with the adventitia. And again, another example here, here, and so on. It's one of these examples where if you see one and you learn to recognize it, they all look the same. This is an example of both intra and extramural hematomas. An extramural hematoma is a form first of a rupture. So here's pre-intervention, here's post-intervention. You see the intramural hematoma, and proximally you see the extramural hematoma associated with echolucency because of contrast extravasation outside of the vessel. This is another example of a forme fruste of a rupture in which contrast has left the vessel through a break in the adventitia with accumulation of the contrast here. Sometimes stents come off the balloon. This is an example. Stenting this osteal LAD looks pretty good angiographically. The stent ran into the calcium. The stent got stripped off the balloon, and you see it floating freely in the left main, totally unexpanded. A couple of words about CTO intervention, because IVUS is useful in identifying and crossing an ambiguous proximal fibrous cap, connecting the proximal and distal true lumens, assuring that the distal lumen will be implanted into the true lumen, and identification of complications and stent optimization. Here's a stump occlusion at the ostium of the LAD. The IVUS catheter is put into the ramus. We can see the IVUS catheter in the ramus. You can see that the LAD is here, and the guide wire is directed to penetrate the LAD proximal fibrous cap. This is a guide wire retrograde in the subintimal space. You can see that the IVUS catheter is in the true lumen, but the guide wire is here in the false lumen, and by aggressive dilation, they can now enter the guide wire into the true lumen, and therefore you have connected the true proximal and distal lumens. Here's a couple of examples of complications. The IVUS catheter is in the true lumen distally with a large diagonal branch. This is the true lumen. This is the false lumen, true lumen, false lumen, true lumen, false lumen, and large dissection down to the media. That continues, and then we connect the proximal and distal true lumen. Another example, true lumen, perforation. You can see the break in the adventitia here and here. True lumen, false lumen, true lumen, false lumen, true lumen, false lumen, and then you connect the true lumen proximally. We can use IVUS to assess stents at follow-up. Again, maybe OCT is better, but in terms of routine examples, here are several. This is early in-stent restenosis in which the neointima is hypoechoic. This is typical garden variety in-stent restenosis, and this is in-stent restenosis with calcium in the intima, as well as attenuated neointima in that you don't see the stent struts. So this indicates calcium. This indicates neoatherosclerosis, and so this is a late in-stent restenosis secondary to neoatherosclerosis. These are three less common causes of in-stent restenosis. The top one is actually a proximal edge restenosis, because you can see that the stent itself is free of neointima, but you see a large plaque burden proximal to the stent with lumen compromise. This is an example of in-stent restenosis from chronic stent under expansion. Stents rarely recoil chronically, at least metallic stents rarely recoil chronically. So here's the distal LAD, or the mid-LAD. You can see at the site of restenosis, no neointima with a severely narrowed stent that was never expanded at implantation, and then the proximal reference. This is in-stent restenosis from a crushed stent. You can see that the stent is pretty decent distally. In the middle, you see all of the stent metal at the side, and then proximal, you see that the IVUS catheter is inside the stent, maybe somewhat distorted. At the time of implantation, the operator lost wire position. He went through the stent, outside the stent, alongside the stent, back into the stent, and in post-dilating, he crushed the stent to the vessel wall. Late acquired malapposition is usually the result of positive remodeling. So we're back to the concept of remodeling, but in this case, remodeling is a reaction to the stent implantation, and it was especially common with first-generation DES. You see the stent at implantation, full apposition and expansion, and at follow-up, here's the stent, here's the vessel wall, here's the malapposition, because the vessel has grown from here to here. And lastly, a couple of common artifacts. Artifacts in any imaging modality are one of the things you must learn to recognize. Non-uniform rotational distortion happens when the drive shaft of the ivus catheter is grabbed or it's tight, either with your hemostatic valve or tortuosity in the vessel, so that the ivus catheter doesn't spin uniformly. It whips around, and you get these crazy-looking smearing kind of thing. Air, particularly in catheter-based imaging, causes the image to get very, very weak. Here it is with the air flushed, and the image pops up. And blood stasis can obscure the lumen, but all you have to do is flush through the guiding catheter, and you see that the lumen clears up nicely. So, in 20 minutes, 45 or so slides, that's a very, very, very quick overview of the kinds of images you can see with intravascular ultrasound. Not everything. You may think I covered everything. Trust me, I didn't. And I covered the most common things only with one or two examples. But like anything else, if you're going to use the information, you have to learn to interpret the images accurately, learn to ignore artifacts, learn what is important and what is not important, and then it becomes very similar to using angiography, but with greater precision. Thank you for your attention.